Thank you all so much. I hope you had an inspiring afternoon as we thought about the day and laying out the challenges that were before us, some of the solutions that were already in play. We thought about how we can send everyone out the door inspired to do more. And sometimes you put these programs together, you never know how it's going to work out. And you also sometimes meet people that you probably should have met a long time ago. And I think Ashani is one of those people I probably should have met a very long time ago. And I think she's going to come and inspire us to think about how we engage in more partnerships and how we really continue to drive change across our own healthcare ecosystem and across other industries as well. Her bio is here, of course, but I'll just give you a couple sentences from it. Dr. Ashani Johnson-Turbes, yes, is Vice President and Director of NORC's Center on Equity Research, which is a multidisciplinary center situated in NORC's academic research centers. The Center on Equity Research focuses on expanding culturally responsive research. We've heard a lot about cultural competency and partnerships and embedding equity principles in social science research across a range of activities and departments. She received her BA at Hampton University and her PhD at Purdue University with continued studies in political science and quantitative methods at Leiden University and the University of Chicago. And without further ado, Ashani.
I have all these notes. I'm going to be doing a little bit of reading to you because I have a story to tell, but I like to think it's a somewhat compelling story. But I initially thought, I don't know why I had it in my brain. I wasn't preparing clearly as well as I should have and thought I had 15 minutes, but I have 45. So I just said to Niesha, I said, all right, it's on then. That's all good with me. So given that I have a little bit of extra time, I'm going to talk through all of this, but I'm also going to start by just telling you a little bit about who I am, because I think that it's nice to know when people speak. It's nice to know a little bit about their story and who they are, about the community that I come from. You're going to hear me say the word community so many times over the next, I'll say 30 to 40 minutes. My name is Ashani Johnson-Turbes, as you know, and it says up here. I am the Vice President and Director of NORC Center on Equity Research. The Center on Equity Research is a new center. It was launched in May of 2022. NORC at the University of Chicago has what is called the Academic Research Centers, and it is one of the academic research centers. There's an academic research center on STEM. There's one on aging. I won't remember all of them, but the Center on Equity Research is one of the newer ones. And it was formed when NORC took on the development of a DREI strategic plan, Diversity, Racial, Equity, and Inclusion Strategic Plan. And one of the things that was determined as an action item in the strategic plan was to develop the Center on Equity Research. I worked at NORC from 2017 to 2020. And then I left for a brief stint in corporate America. I worked for McDonald's Corporation for a short period of time, and then I came back to NORC because I learned that as much as I love corporate America, it wasn't my jam, and I really love NORC at the University of Chicago. I am academically trained as a political scientist. I also studied quantitative methods because I fancied I was going to be a statistician, not because I like it. I don't. But I am going to tell you my decision to to focus on political science, public policy, and quantitative methods. Y'all, it was entirely motivated by sexism and racism, because in my program I was one of only 2 Black women, and every time I would go into the stats classes they'd be like, oh, are you in the wrong class? So it's like nobody expected me to be able to do it, and I was like, all right, I got you. And so that's why I did it. However, years later, I found my people really in public health. So I was doing work in public health, and specifically in health communication for about 20 years. And I still I work extensively with our public health department at NORC. I'm going to do a shout out for the Society for Health Communication, folks that are here that are involved in public health and or in health communication. I'm looking for Mike Grilla. I don't know where he is exactly. He's over there. He's the president of the Society for Health Communication. I'm the vice president of that society, and we work really closely together. I went to Hampton University, as Niesha noted. Yay, HBCUs. The real HU. I don't know if there's any Bisons here. And then I went on to graduate school at Purdue University, and then I also studied at Leiden University. It is in it's about 30-minute train ride outside of Amsterdam, and that was great. And I did some work I entered a doctoral traveling scholar program at the University of Chicago. They let me come and finish my last year PhD coursework there. So I did that. I am from Minneapolis, Minnesota. You're going to hear a lot about that in a minute. I don't know if there's anyone else here from Minneapolis, Minnesota. Hello. St. Paul. No, but I'm going to talk about St. Paul. I'm going to talk about Rondo. If you know anything about Rondo. Okay, it's just exciting. I love that you're here. So I'm from Minneapolis, Minnesota. And when it's time for me to go to college, I was determined, I'm going to stay in Minnesota. All my friends are staying in Minnesota, or maybe they're going to Wisconsin and going to Madison. And my mom said, you can go anywhere you want. And I said, oh, that's exciting. And she said, it has to be an HBCU. And I was like, wait, what? And she's like, any school you want to. But you have to go to a historically Black college and university. And she gave me a variety of reasons why. Most successful African Americans coming out of HBCUs. And I was sold, and I applied to 3, Howard, Hampton, and Spelman. And I chose Hampton. I've lived in Chicago. Like I said, I've lived overseas. I lived in Amsterdam, or just outside of Amsterdam as well. My family is also from Virginia. I spent my summers in Richmond, Virginia. So I share all of that with you just to tell you a little bit about who I am, my story, how I got to where I am. I am deeply committed to work that is to advance health equity, to advance all equity, economic equity, educational equity. And I remember I had a friend of mine, I wasn't even a friend, it was somebody I was working with, said to me, maybe several months ago, and they were like, Ashani, how long have you been doing this kind of work? And at the time, I think I gave the answer last 20 or 25 years, I've been in school, but no, I've been thinking about this a little bit longer, y'all. I have been doing this since middle school. And the reason why I say that, and I know that many of the folks in this room have been doing this work since elementary or middle school as well, ever since I recognized and realized how the world sees me and how I see the world, because of how the world sees me as a Black girl, a Black woman, a dark woman, ever since I realized that, I'm like, I am committed to embracing and promoting and advancing equity and social justice in every space that I enter. And it is so wonderful at 50-ish years old that I feel like I'm like my whole self. I'm my whole self at home, I'm my whole self at work, I'm my whole self up here. And it's wonderful to be just unapologetically who you are. Everybody do it. So, okay. Since I had time, I figured I'd do that. I am so inspired and honored to be here. Like, my soul is nourished, and it has been nourished, I think, since I walked in the room a little bit late, because I was coming in this morning from Chicago, and I saw that panel of smart, strong, beautiful Black women up here. I was like, oh, this is my jam. Like, this is good. And listening to everything that's been said throughout the course of the day. Like I said, my soul is nourished, I'm inspired. And I'm at a little bit of a loss for words, even though it doesn't seem like it at this moment. My mom told me last week when I said, oh, Mom, I'm at a loss for words about something else. And she was like, that is very hard to believe, Ashani. She's like, you have enough words for all of us. So, but what I'm gonna do is I'm going to do some reading of my paper, and when it helps me just calm down and be comfortable, I start to talk really fast when I get excited and passionate about things. If at any moment and all my Minnesota accent comes out, if I start going really fast, you literally can put your hand up at me and say, slow your roll, and I will. Thank you. Okay. All right, you guys. not y'all, you guys. um, but I'm gonna go through what I have here on the sheet, but I'm going to, in the course of doing this, I'm gonna go off scripts a little bit because I want to pepper it with what I've heard today. I've been sitting at the back of the room over the course of the day and like writing down quotes and things from different things that people have said that I can include, because I think much of it has been just outrageously powerful. But community is our place. In community is where we live, where we work, where we play. It is where we send our children to go to school. It's where we go to work. Perhaps attend the schools that create pipelines for future healthcare workforces, where we enter healthcare systems and we receive our care. And as we heard from Dr. Matthew in the very first panel, community must be meaningfully engaged to explore how to foster an equitable healthcare system. I think that community or place, akin to neighborhood or built environment and community context in terms of the social determinants of health, I think it's actually the most important social determinant of health. In fact, research tells us that zip code and place carries more weight in terms of its impact on our health outcomes than our genetic code, right? So place, where we live, where we grow, where we play, that is what significantly impacts our health. I know I'm preaching to the choir a little bit. Many of you know a lot of what I'll share. Thus, community is a driver of racial health inequity or equity. And this is why I think a story about a community and its disruption is really important. As I said, I was born and raised in the 1970s and 80s in Minneapolis, Minnesota. In Minnesota, in the 1930s, the Summit University area was part of a large and thriving Black community that centered around Rondo Avenue. Rondo was named for an early settler, Joseph Rondo, a Canadian who moved there in the 1850s with his Native American wife. The close-knit community in the Rondo neighborhood is situated in the city center, and it extends to today's more affluent Summit University neighborhood and north to University Avenue. These things might not mean a lot to you, but just understanding, I think mostly that it's in the center. That's good real estate, y'all. By the 1950s, about 85% of St. Paul's Black population lived in the Rondo neighborhood. The neighborhood was divided into sections that included, and these are real names, Oatmeal Hill and Cornmeal Valley. The Rondo neighborhood and community was in part organized around Pilgrim Baptist Church. It's just a map of Rondo at the time, and this is Pilgrim Baptist Church. This is actually where my family and my grandparents went to church, and it's also where both of my grandparents' services were held when they passed. In Rondo, the thing is, Minneapolis, St. Paul is often considered progressive, but where structural racism existed and still exists, and sadly thrives, and the rest of the world, the rest of the country and the world have seen this in recent years, particularly obviously with the murder of George Floyd. Rondo Black residents were proud homeowners, and they built a thriving community. It's a picture outside, Black men outside of Pilgrim Baptist Church and a group of women outside of Pilgrim Baptist Church. I love this picture. It's just some women walking in the neighborhood, holding their children. I thought it was really beautiful. My favorites are coming up. This picture actually on the left, I think that's one of the groups that my grandmother was part of. It's called the Just for Fun Girls. I'll tell you more about them in a moment. And here's a group of men that were congregating. And here's some more pictures. I think that's the Just for Fun ladies again. And pictures from, there was a prominent drugstore. Forgive me for not remembering the name of the drugstore. Oh, I can look down here as well. In Rondo. And then some pictures of the community members congregating. I think this might have been, looks like it was in the basement of Pilgrim Baptist Church. But you can see from these photos, I mean, this is a thriving community of middle and upper middle class Black people in St. Paul, Minnesota at this time. This one I love because it just shows so much joy, right? Like just dancing and having a good time. I don't know if they were doing the electric slide. Who knows what was happening here? But every time I see this picture, I just see the look on her face, and I'm like, oh, it's just in one's element, with one's family, with one's people, in one's community, in their place. You can almost feel it. I think I can feel it coming off her skin when they're dancing. This absolutely gloriously beautiful couple are Earl and Anna McGee. In 1950, this young couple was married. These are my grandparents. They were married and they started their lives together in the Rondo neighborhood. Earl, it's hard to call them Earl and Anna, but Earl, my grandfather, was a school teacher, and my grandmother was a homemaker who enjoyed spending time with the many other wives and mothers, cooking and building and raising their families. And like I said, she and her friends formed an organization called Just for Fun Girls, to do ladies' time out together, also to come together with husbands and families. Here's what I remember the most, y'all. I remember them sitting around drinking gin and tonics, smoking those long, brown, skinny cigarettes. Virginia Slims, I don't know what they were. This is like a memory that I have, but that seemed to me what the Just for Fun ladies would be into as they got older. The McGees received health care from local health providers in Rondo. Their eldest daughter, Carol, my mother, attended McKinley Elementary School, and she also went to Bible vacation. Oh, maybe this might be another one of the Just for Fun ladies. This is my mother when she was little, and her younger brother. So they started their family here in the Rondo neighborhood. Like I said, she went to McKinley Elementary School and Vacation Bible School in Rondo. My mom would tell me stories about feeling so nurtured and so safe in Rondo, and that she would walk to school with her two best friends, and they would just have a good time. They'd walk to the Hallie Q. Brown, Vacation Bible School. I don't even know which one is her. I know she's in there. My my uncle told me that she's in there. This is Hallie Q. Brown, the community center. She told me she'd walk to the Hallie Q. Brown Community Center with her friends, and they'd had such a good time. I think told me she smoked her first cigarette out behind the back of Hallie Q. Brown Community Center. But the community center was a thriving spot in the community where folks would go, and adults and young people, and just be able to spend time together and congregate and socialize. The McGee family was young and working to own their own home in Rondo. They were happy and they were healthy in a community that they cared for. They were active in that community, in the church, the community center, with the drugstore. They got their health care there, and that community cared for them. That was their place, and they were healthy. In the 1920s, city leaders started discussing the need for a road to connect the neighborhoods north and south in Minneapolis-St. Paul. And in the 1940s, city officials commenced research and a campaign calling for the interstate to go through city neighborhoods. City officials determined the need for an interstate and determined that its location would be best situated near the city's center and directly through the Rondo neighborhood. Despite, y'all, the opportunity to place the interstate just north, a little bit north, 3 to 5 miles, it might have been, north of the Rondo neighborhood in an area that was not inhabited but had just the railroad tracks already there. Despite that opportunity, they concluded it should go through Rondo. Thus, facing intimidation and, in some cases, sledgehammers wielded by the police during the night to reduce homes' values before appraisers had the time to appraise, Rondo residents whose homes were slated for demolition they received only a fraction of their value as compensation, and the residents were violently displaced to make room for the interstate. That is in 1956. This is not 1920, not 1930. In 1956, Rondo was destroyed. The neighborhood was destroyed by Interstate 94. Homes were torn down and neighbors were separated, and some of the vibrant and dynamic culture that made Rondo special was scattered along its edges. On December 9th, 1968, the interstate was completed. Let's see if I have that. The interstate was completed through the city and open to the public. And it had destroyed at that time, I think, probably about 400 homes for the interstate to go through. I am certain that the research that was conducted to recommend that I-94 go through Rondo was not inclusive, was not equitable, was not focused on elevating equity in that community or thinking about the community's health. I surmise that the questions that were likely asked were, what is the most central location to put the interstate? Where can we best remove homes that have lower value? Where's a community that doesn't have a whole lot of political power to put the interstate through that neighborhood? Where might we anticipate the least pushback to eminent domain? And how can we best address sales declines by moving people and goods? This is capitalism at work, right? Most of the time, oftentimes. Of course, I'm telling you this story. This happened in lots of different neighborhoods and communities around the country. At the heart, let me back up. Questions that would have been attentive to promoting and elevating equity would be things like, might the interstate cause harm to the people and communities? How can we preserve community health? At the heart of efforts to promote equity is the conduct of inclusive and equitable research, which requires engaging communities. We've talked about that all day long today. I know from my discussions with family and friends who lived in Rondo and those that have studied that time that city officials and researchers were not focused on inclusive and equitable research. And they certainly were not committed to or interested in engaging communities and people in those communities to understand what they thought about the interstate going through that neighborhood. Although Black home ownership rate in the United States increased from the 1940s to the 1970s, since that time, Black home ownership decreased in St. Paul, Minnesota. In 1950, the gap in home ownership rates between Black and white Minnesotans was about 20 percentage points. Over 70 years later, that gap more than doubled and is today one of the largest in the country. In the years after losing their home and after leaving Rondo, Earl and Anna McGee were both diagnosed with diabetes and with hypertension. Earl suffered multiple heart attacks and strokes, and Anna passed away from a blood clot in the brain stroke at age 63. Clearly, I cannot attribute health inequity in St. Paul or my grandparents' health and struggles to community disruption by the I-94 interstate that cut through their home. But as a fourth-generation Minnesotan, Black Minnesotan, I can say with confidence it did not help. The research and the recommendations that led to the decision to place the interstate through Rondo did not contribute to health equity. You may be asking, why is Ashani telling us a story all about a highway and an interstate that cut through a neighborhood? It is because this highlights what we've talked about today, community and health. It is a cautionary tale of what happens when we do not work to advance health equity through community. If you attended all or most of today's panel discussions, you bore witness to what I think is a common thread a common thread through all of the presentations and panels and discussions. It is the advancing, what I'm calling the advancing health equity through community thread. So I want to talk about what I mean by that. I mean the explicit or implicit, most of the time I think it was explicit, mention in all of the panels about our responsibility to advance health equity by acknowledging structural racism present in communities and healthcare systems. As Dinah Matthews indicated, and I quote, to disrupt this trajectory to create sustainable change and improve health outcomes. In order to advance health equity through community, we have to disrupt the trajectory and create sustainable change and improve health outcomes. Number two, advancing health equity through community means recognizing that social engagement and social cohesion have an impact on emotional and physical health, as it did in Rondo. It means centering community and culture in our work, especially that of historically marginalized and minoritized communities and peoples, and microcultures, the cultures within those cultures. As Dr. Ebony Repress, I hope I'm saying that right, Respress, you correct me later, said in the digital health panel, quote, the people with the problems have the solution, so center them. Dr. Smith put an even finer point on this and said, quote, make patient-centered really patient-centered, like centered on that community and those patients. Number four, by advancing health equity through community means engaging and empowering community in different ways in all phases of the research cycle. In the policy session briefing, Romero asked panelists directly, how do we grow the capacity of community organizations and health advocates so we have a bigger impact on health equity issues? This point about engaging and empowering communities in all phases of the research cycle is it's what keeps me up at night. And not in a bad way. I'm a social scientist, and so what I think about is I think about these issues in terms of research, like what we can do, what are the questions that we ask when we're starting our research, how are we going to collect the data, how are we going to analyze the data, and how we're going to disseminate it. Those are the things that are commonly on my mind. So from my perspective, engaging and empowering community to do that is essential, and that is advancing health equity through community, if that makes sense. Those of us that are doing this research and work, we know this. We know that our community and our systems shape health. We know that attentiveness to culture and place and engaging community is what we are supposed to do to embed and elevate equity. But how? I always talk to my colleague, I'm looking right at Lucy and she's smiling because I say this all the time at work. I'm like, oh, we're so good at talking about what we're supposed to do. And we're pretty good at talking about why we're supposed to do it. But how? How am I supposed to do it? There's not to my knowledge, if someone knows it, please come up afterwards and tell me, a textbook that says exactly how I am supposed to do and conduct inclusive and equitable research. I've determined I'm going to have to write it. So anybody that wants to join, come on. The tricky part is that there are multiple permutations of how to do it. Like there's not just one way. I'm getting ahead of myself. I'm sorry. Let me go back up. I see because I went off script. Because I'm a social scientist, I mentioned this, I think about how to do this through research. I think and recommend that we elevate and we embed health equity solutions by embedding inclusiveness and equity into research processes and the full research cycle. I can and will say here and anywhere I can with my whole chest that if you authentically put this in the research process, in the cycle, health equity, educational equity, economic equity, environmental equity is an almost inevitable outcome. If I decide in the conduct of conducting research on, say, for example, how to promote increased awareness to early detection and breast cancer among Black women between the ages of 40 and 64, that's so specific because I literally did this. I'm going to ask certain questions. I'm going to ask that group, I'm going to engage that population. I'm going to ask them about what resonates with them, ask them about what they're afraid of or not afraid of, ask about how religiosity plays a role in their decisions to get mammograms or not. I'm going to embed that attention to I'm going to include and embed attention to inclusiveness into the types of questions I ask all through my cycle. I'm going to choose a foundational framework for the work that is focused on equity. I'm going to choose intersectionality theory. I'm going to choose empowerment evaluation. I'm going to choose culturally responsive evaluation as the bricks and the mortar and that are the foundation of the research that I'm putting together. Right, I'm going to start there, and then I'm going to talk about the questions I'm going to ask. I'm going to ask about power dynamics. I'm going to ask about power sharing. How do I share power with the community that I'm engaging? I'm going to think about how I excavate the stories of that community and how I elevate it and how I talk about it. Again, I got ahead of myself. I'm going to come back to it. Years ago, I heard a prominent Harvard sociologist talk about health disparities. This was at a CDC conference, and he detailed years of injustices and racism leading to health inequities. And I will always remember, he was talking about the history, like he must have gone back, like, I don't know, 100 years. Talked about, he invoked the name of W.E.B. Du Bois, which I will do as well. And I will always remember that he said, solving the problems of health disparities to advance health equity. He looked at all of us and he said, y'all, it's not rocket science. And he paused and he said, it's harder than rocket science. And that is because it is undoing years, decades of policies and practices that purposefully generated inequity. We know this, we know it is built in, baked in, into the DNA of the country. We're trying to undo something that is so deep, like the roots are so deep. So it's not rocket science. This is hella hard. It's harder than rocket science, and it's going to take time. I can't remember who it was. It was the long game. Somebody said long game in the last presentation. And we got to have our eye on the long game, right? I remember I was telling my colleague I was at a presentation. This was back in the early 2000s. And it was a woman, she was a scholar, she must have been in her 60s at the time, and she was talking, she'd been studying health equity for her entire career. And she literally put her hands on the podium and she's like, yeah, I am tired. I was talking about this in 1960. I was talking about this in 1970. I was talking about it in 1980. And I'm here talking to you about it in 2010. And we are here talking about it in 2022. Long game. It's going to take time. And one of the things that we can do to address that is to make sure that we're embedding these things in the way we ask the questions, what we ask, how we ask, and engaging communities. I'm sharing what the scholar shared with me to stress that also there's not a magic bullet or bullets. There is not one solution or even solutions where research is concerned. There are multiple permutations, as I noted, of how to conduct inclusive and equitable research that elevates equity, health equity in particular. We've captured many here today. I know that my colleagues around, we're capturing solutions, and I know Niesha's going to talk about that and a call to action shortly. But I'm also going to give you, even though I'm saying there's not probably 10 or 20, but I'm going to give you 6. I like to think, I say sometimes in 3s and 5s, this time I came up with 6. I like to think of them less as the how you do it, like how you elevate and embed health equity solutions into communities and organizations, but more like kind of how principles, if one can have how principles. That's what these are more like. I should have put them on a slide. Forgive me, I didn't. I got too caught up in looking at all of the beautiful pictures. Number one, examine your own biases, right? So on your teams and the groups that you're working with, and when you're working on research projects or specifically on the development of programs and policies or the things you're going to recommend to decision makers, examine your own stuff, right? Like, even though I clearly have intersectional identities, I also have blind spots, right? I'm Black, I'm female, I'm middle-aged, but I'm not gay, right? I'm not short, I'm not a Latina, I'm not like, so there are things I don't know and I want to know. And so examine any biases and gaps that you have and have your teams do the same thing. Whole team working together. If you're about to start a research project, you're about to start development of a program, a policy, an intervention, or a campaign, sit down with them and do it. It's hard and it's not comfortable, but it's good. And it is part of doing, from my perspective, inclusive and equitable research. Engage communities. Dr. Hernandez said, make community your equity partner. I loved that. Make community your equity partner. Related to that, create community advisory boards. That's like I won't say it's an easy way to do it, but it's one way to do it that's like sort of a tangible thing to do. Engage people with lived experience. I've heard that consistently throughout the course of the day, lived experience. I'm working on a project right now, and it's with a client, and that client has asked us specifically, they want interviewers, but they just don't want, and they want interviewers to interview populations, people experiencing homelessness, people I think with emotional health issues, and then older adults. But they specifically said, we want the people that are collecting the data from those populations to be people that have lived experience. We are experts. There's a whole bunch of PhDs and JDs and MPHs and MAs in this room, but lived experience is real expertise, and it's worth it and it's valuable. Include that on your teams. Hire those people, and let me be real when I say this. My sister from the Mississippi Delta mentioned this earlier. Pay them for their expertise and their lived experience and the contribution that they make. Dr. Parrott also brought up co-authorship, so I thought that was wonderful in thinking about co-authoring with community members as well. So that's a way to engage communities. That's my number two. Number three. So also I would share that also increases our credibility and makes the data more trustworthy. Number three, investigate hierarchical power structures and shift that power. So make it our responsibility to guide and to shape research or policies and programs, but shift that power. It's not just like, oh, I recognize that there are power dynamics and differences in terms of how people, interact with one another because of social constructions of race and other power dynamics or hierarchical power dynamics, but shift that power as well. Actively work to do that. When you create instruments, number four, include research questions that help you understand systems and structures, not just people's health behaviors, but the systems and the structures that contribute to those health behaviors. I'm preaching to the choir. I don't have to say, oh my God, I'm at 5 minutes. Goodness. Okay, here I go. Girl, I was afraid I only have 15 minutes. I was so wrong. Okay, I can do it. I can do it. When you create instruments to gather data and answer those questions, cognitively test the instruments. A lot of times we have, like in the work that we're doing, we don't necessarily have like either the budget or the time for cognitive testing to make sure that the questions are resonating and that people understand them. Do it anyway. It is like it's one of the things to do when you're doing inclusive and equitable research, and to elevate equity, cognitively test the instruments and have the people with the lived experience help you with the cognitive testing of the instruments when you're collecting data. Here's one that's really important. Number 5, adopt the principle of do no harm. Consistently ask yourself and your teams, is what we are doing or what we are asking or what we may recommend based on the results doing harm that can contribute to inequity? As Abner Mason said, quote, use data to help, not harm people and communities. And number 6, use the data obtained through your research to excavate and tell human stories. So now, consider, how would pledging to advance health equity through community and prioritizing these 6 how principles change the questions that city researchers and officials asked and the decisions that were made about the placement of the I-94 interstate through Rondo? It would have, I think it would have made a big difference. I'm not so naive as to believe that there weren't other elements and kind of nefarious elements at play in terms of wanting to have a highway go through a Black neighborhood. I'm fully aware of that. But I use it as an example of the way one can conduct research to elevate health equity. After leaving Rondo, Earl and Anna moved from St. Paul to Rochester, Minnesota, a predominantly white community in southern Minnesota, far from Rondo. Although my grandparents suffered the indignity of racism and many of the health problems that are common in Black communities, they also raised 4 healthy, wonderful children. My mother and her 3 brothers, one of whom went on to be the first Black public defender in Minnesota. The McGees were active in the Rochester community, especially in the Lutheran Church, and they contributed to the health of that community, and that community contributed to their health as well. I encourage us to conduct inclusive and equitable research when we're developing programs and policies and campaigns and interventions. Attentive to those 6 how principles that I shared, and to ask the hard and sometimes uncomfortable questions about structural racism. And to engage people with lived experience to tell stories about places like Rondo, about people like Earl and Anna McGee. This is to recommend the creation of programs and policies to dismantle structural racism and advance health equity. Now, I'm going to ask everyone to just take a deep breath. And when you let out the breath, okay, wait, don't take it yet. I'm going to ask you to take the deep breath, and then as you let it out, I am going to read to you a quote from civil rights activist W.E.B. Du Bois. I think it is only fitting that we end with a quote from Du Bois, given that he is a sociologist and one of the preeminent scholars and first scholars working on bringing to light health disparities, right? And he told us how to elevate and embed health equity solutions into communities and organizations. So take a deep breath, and either with your eyes closed or open, totally your choice, you're going to sigh it out like you're in yoga class, if you know yoga class, like, and then you're going to let it out. And as you let it out, as long as you want to, I'm going to read to you the words of W.E. Du Bois. Everybody in, out. Here are the social problems before us, demanding careful study. Questions awaiting answers. We must study, we must investigate, we must attempt to solve. And the utmost that the world can demand of us, not lack of human interest and conviction, but rather the heart quality of fairness and the earnest desire for the truth. Thank you.
Okay, so you scan the QR code. I mean, yeah, thank you. Thank you. We need to hear what we want to do, what we need to do differently and better. I just wanted to spend a couple minutes talking a bit about how we got here. Melissa talked about the Multicultural Health Equity Collective that was started about 8 years ago, and we have some of our partners here in the room with us. Pfizer has been actively listening to how we should improve. And this is an example of what they told us. So a year or so ago, we interviewed about 4 of our partners. We had a survey about systemic racism. Nurses, physicians told us not only about their own experiences, but what they saw and how care was delivered to patients. And, our core competency at Pfizer is the discovery of medicines. But we had this information in our hands, and we said to them, how should Pfizer join this conversation? How could we help? And what they told us, very loud and clear, use your power to convene the experts. So we come to this conversation not as experts in health disparities. We come because we know health is everything, and without it, we have nothing. And so what we hope you heard here today was from leaders who are passionate about this work, identifying solutions that are not rocket science, but they are hard, right? Hard to get it done. It will not be accomplished in our lifetime. Therefore, we must put our armor on, but we must also make sure we're mentoring others to continue this work, letting them know that it may not happen in their lifetime either, but they have to be here to do that hard work. Hard work. So what we're doing is not for nothing. And some nights it feels difficult, hard to go to sleep, wake up at 3 a.m. Did I do the right thing? What else is there to do? Not in our lifetime. It won't be in our lifetime. I want to thank our co-convening partners, National Minority Equality Forum, NACCHO, Century Foundation, the Morehouse School of Medicine, for really helping us and meeting with us week after week to develop the day's lessons, the day's panels. We went to them with ideas. We said, look, these are ideas, they're thought starters. Help us make this a great day for everyone. In that survey, I hope you tell me it was a great day for you. And so I just want to go over a little bit more about what we heard today, right? We heard about community, but what I want us to remember is that we are all part of the community. It's not like everyone in this room is going to a community. We are the community, right? And so our lived experiences are important. When I stand up here and say I'm the oldest daughter of a single mom who was a correction officer at Rikers, who lived in subsidized housing, that's who I bring into every room that I walk into. So that our stories matter, our voices are important, and we have to continue to tell the stories. And we don't need to tell the stories for those who can't come into the room. Everyone in here has the authority and the power to bring them into the room. We have emails, we have social media. People can tell their own story. We don't have to do that for them. And guess what? That takes a lot more off of our shoulders. We can tell them how they can tell their own stories. I think we heard that today as well. We also heard today that health happens in between visits. 80 to 90% of health happens before they get to the doctor's office. And so how can we encourage companies, organizations to make sure that we are not sending people after that doctor's visit back to the environment that made them sick? The environment that doesn't feed them, doesn't give them the job where they can afford to take time off work, to take their kid where they need to go, or to care for their own health. There's much more to do. Today we focus on a lot of different areas: research and data, policy, workforce, health facility and delivery, but without making sure that we don't have food deserts, pharmacy deserts, deserts. We will be here in another 10 years, like you were saying, having the same conversation. So let's think about this in people, process, and resources. People. Center lived experiences. Disrupt decision makers. If the people don't look like those who we know need the most help, that is not going to be a decision that's going to get us one iota closer to health equity. So we should call people on that. Here's another voice you didn't include: We know this organization, they're doing this. Here's a way this can be done differently. Disrupt decision makers. Prepare the workforce. We heard a lot about the future of the workforce, people who are coming up in the system. But guess what? The people who are there delivering care today, who never heard these conversations, how do we get into CMEs with this type of conversation? We have to not only focus on the future, but those who are delivering care today. And we heard in the workforce pipeline discussion, was there, how do we ensure that we're building culturally humble workforces? What does that mean to you? I think that's something we can marinate on. Like, I don't think I know any other culture but the one I grew up in. And so when I'm talking to people and they say, hey, Niesha, your images are not inclusive of Afro-Latinas. Oh, my bad. I did that wrong. I'll fix that. Listen to others. It's the only way we'll move forward. On processes, we have to convince people that better models of health help everyone, not a zero-sum game. We saw all the data that came out of COVID. In the very beginning, of course, we saw Black, Latino, other underserved communities dying at a higher rate. Eventually got to rural America, though. Why is that? Because it's about economics, it's about power structures, and sometimes it's about convincing people to vote against their own best interest. So we have to make sure that people understand this is for everyone. All boats rise. How can we influence governance? The Black Directors Health Equity agenda, they have a document that we can all use and download. If you need it, we can get that for you. But it really talks about how you can influence governance in your own environments and how to hold people accountable. And the one thing we talk a lot about in the process and the how is the importance of partnerships. Who are we working with? Who aren't we working with? Why aren't we working with them? Calling ourselves out on our own biases if we haven't included the right people. Another thing to think about as far as process. And the last area is about resources. And this is still something, and I talk to all the panelists and the moderators, this is the one thing I still don't have. How do we make sure that we're unlocking the dollars that are out there to drive this topic? How do we talk in a way that those who think about quarter to quarter earnings see value in this and give dollars and invest dollars in health equity? We keep saying we're not going to get where we need to go until we have more resources. But collectively, as we think about what comes next after we leave this room, it really is about how we talk in the language of those who hold the purse strings, not the wallet. And so the call to action is this: do not accept the status quo. I don't think anyone in here does, but let's encourage others to rise up, find their voice, say, this is not it. This is not it. How can we do something different? We all know the system is working as it was designed. It's not a mistake. Disrupt the system, get the money, embed health equity in everything we do, and work with others to do so. It has to be sustainable, and it won't be in our lifetime. The next steps from today are several. We look to collate all the information that we've heard today and even other ideas that you all may want to contribute into a paper that can be leveraged so people can figure out if they can just, adopt that model as it may present itself or adapt it to fit their own communities. We don't want the conversation to stop here. We know it won't, but we want to make sure that we hear your voices in the creation of that paper next year. So if you're interested, I think you saw the question in the survey for those of you. Just saying, back to the survey. You can, again, join us in continuing the conversation and amplify what we know will work to move the needle on health equity. And so as we close, again, a big thank you to everyone, to my colleagues, Amaryllis and Roy and Yartish and Molly and Wendy and Ratna. I forgot somebody. You can get me later at the Mexican restaurant. But I just want to thank you all. This was an idea that we had last year. It took so much to get here in the midst of so many other things. But, you know, that old girl, COVID, she's not going to keep us down. And there's a lot more that we can do.